For the next session for the day, we take immense pride to introduce the alumni of ICH, Dr. Revati Ma'am, for renowned pediatric hematologist. She is credited with a large series of bone marrow transplant across the country. The most challenging cases of hematology has always been a cakewalk for her.
Thank you, Dr. Srinivasan, and to ICH to always come back. It feels like coming back home, and as Rama said, it's a chance for us to meet. Actually, this is the first real meeting I'm addressing after COVID. So it's good to be back and to see so many young faces. I know all of us are nervous being here, but here we are, and we'll try to make the best use of the next 45 minutes. I think pancytopenia is a topic that a lot of you would find it hard to read up, and actually when you see a child, what are you going to do? The child is not going to come up to us and say, I have pancytopenia. So the message from today is every empty bottle is filled with story. So it is up to us to look at what story the child is going to tell us. So we need to know some basic physiology about our bone marrow, and when we know what is normal, then only we can appreciate what is abnormal. Some definitions, what do you call cytopenia? And then we perform a root cause analysis. What caused the cytopenia? For example, iron deficiency anemia is never a diagnosis. What caused this child to have iron deficiency anemia? Only then we can help them. And I've got a few case discussions, and I'm going to request to make it as interactive as possible, because most of the time this pancytopenia, you see a lot of people zoning out and nobody wants to participate because they feel it's all too much. And then I'll only spend a couple of slides on outline of management. So this is something we all need to know, that we have a beautiful garden inside us, the marrow, bone marrow. It's working very hard. As you're sitting here simply looking at me, your bone marrow has stem cells, and some of them are resting, some of them are actively working, and you have cells that are making red blood cells, cells that are making white blood cells, and platelets. So all of these hematopoietic stem cells, they become the myeloid progenitor and the lymphoid progenitor. From the lymphoid progenitor, we get the T lymphocytes, B lymphocytes, and natural killer cells, and from the myeloid progenitor, we get red cells, platelets, and all the granulocytic series. So the seed and the soil. So if any part is abnormal, there's a problem with the seed, there's a problem with the soil, then the blood counts can fall. So this is the only thing. So when you do looking at a case with pancytopenia, a child, is there a problem with the seed? Is there a problem with the soil? What happened? Why did the blood counts fall? So that's how we look at it. So there are three cell lines. You have red, white, and platelets. How does the child tell you I have pancytopenia? You have to listen to their story. What is the red cell story? What is the white cell story? What is the platelet story? So red cells, they will feel tired. They'll not be able to eat. Even if they're forced to eat, they vomit. They can present with severe anemia and in CCF. White cells, predominantly it will be intermittent fever or recurrent infections. And platelets will have skin and mucosal bleeding. So the hallmark of platelet thrombocytopenia is skin and mucosal bleeding. And white blood cells, whenever we look at the gums, we know that neutrophils are healthy if we have healthy gums. So always look at the mouth. Mouth ulcers, gingivitis, all are suggestive of neutropenia. So these are some of the definition. Anemia by WHO, less than 10 hemoglobin, neutrophil count less than 1500, platelets less than 1 lakh. These are the cytopenia definitions. There's another group called severe pancytopenia. So what is the definition? Here, the absolute neutrophil count is less than 500. Why is this important? This is because when the ANC is less than 500, we don't have to have infections from outside. All the bacteria that we harbor in our own body can cause bacteremia and septicemia. So the infections are from the child's own body. As I'm standing here talking to you, my bowels are moving. Some of the bacteria from the bowel, E. coli, are trying to get into my bloodstream. It's very happy because there's lots of glucose in my bloodstream, but the neutrophils stand there. They engulf the bacteria and prevents bacteremia. I brush my teeth, same thing happens. So every event is a bacteremic event, but the neutrophils stand guard. But when the neutrophils are less than 500, this does not happen. So they can move from bacteremia to septicemia to septic shock easily. So it's important to look at a full blood count in entirety. Don't just look, okay, white count's 10,000, okay. The neutrophil count can be only 5%, which is ANC of 500. So it's important to look at the DC. And platelets less than 20,000 and reticulocyte count. So this is some important test. Retic count tells you how active the marrow is. So if the retic response is good, that means marrow is active, it's not a marrow problem. So reticulocyte count gives you a lot of clue on lab evaluation. So when we look at why a child has all 3 cell lines low, we have to ask, is it lack of production or increased destruction? So what is causing the problem? And when there's lack of production, is it a stem cell problem or is it a marrow environment problem? And increased destruction, where are these cells getting destroyed? So it's always important to think about it. So if you look at the hematopoietic stem cell, I told you that there's a common myeloid progenitor and a lymphoid progenitor. And it's giving rise to all the granulocytic series, red bloods and platelets, the myeloid progenitor. And the lymphoid progenitor gives rise to the lymphocytic series, and they jump from the marrow into the peripheral blood. Once the cells are made, white blood cells, they stay for 2 days, platelets for 10 days and red cells for 120 days. That's why if we give someone chemotherapy today, the first cell to get hit are neutrophils. That's why we worry about febrile neutropenia, because within 2 days when the marrow shuts down, all the neutrophils are gone. Then after 10 days platelets, and only it takes 120 days for the red cells to fall. And the recovery happens in the reverse direction. First neutrophils recover, then platelets, and then red cells. So if someone's counts are low, what do? We say, am I dealing with a production problem, which is a stem cell problem, or the marrow environment? Is it defective, something's infiltrating the stroma, or they produce but they're not able to mature and function? So marrow failure syndromes are the aplastic anemia, which can be genetic or acquired. Infections can always suppress the marrow. The marrow environment can be infiltrated with malignancies like leukemia or storage disorders. And maturation, we need vitamin B12, folate, and these can all influence and cause pancytopenia. So who are interested in little bits of pediatric hematology, through digital IAP, we've done a series of recordings for hematology subchapter. So it will be good if you go on to the online access of digital IAP, and we've given some protocols also. It was called Protocon, and it was all released in December. So those who are interested in doing a little bit more, you can listen to those lectures on digital IAP as well. So we've spoken about production problem, which can be from the stem cells or marrow infiltration or maturation defect. And then they are being produced all right, but when they come into the peripheral circulation, these cells are getting destroyed, and this is all primarily immune. Or they can get consumed if there is a big spleen or if there is a big hemangioma, so that's peripheral consumption or destruction. Marrow is producing fine. So this is how we need to think about it, but the child's not going to come and tell you, I have peripheral destruction, consumption problem. So we need to ask the story. Just when you're asking the story, just be mindful that any infection can suppress the marrow. It can be something simple like enteric fever, or following an infection, the child can develop HLH, and then they can go in and have pancytopenia because of HLH. So there can be a combination of both. How will you suspect infection? For the red flags, if there is persistent fever, despite you covering appropriately for antibiotics, there's a progressive fall in counts, and if the child is requiring transfusions for cytopenia and there is transaminitis, these are more pointers towards an infection. So that's what we would think of. So these are some of the studies that have looked at what are the causes of pancytopenia and makes for some interesting reading. And in our country, it's predominantly aplastic anemia when a child has presented with pancytopenia and leukemia. So these are the two main groups. So, what are the clinical clues for marrow infiltration? So, first thing, I look at a child, do they have a node, liver and spleen that's palpable? Whenever they have lymphadenopathy, hepatosplenomegaly, it's not aplastic anemia. When they have aplastic anemia, they have no organomegaly. So, whenever there's organomegaly, it's an infiltrative pathology. And look for dysmorphism. That's always a pointer towards inherited marrow failure syndrome. When there's immune cytopenia, they can have other features like intermittent fever, recurrent infections, oral ulcers. So that's what would the story would be for immune cytopenias. Joint pains. So those are the sort of things. And there's a big spleen, that's consumption cytopenia. So this is the algorithm I've been talking about. If you see all the 3 blood counts are low, you look at the retic. So this is the lab algorithm. What is the retic? Is it low or high? And then depending on the retic, we decide, are we talking about marrow failure? This is when the retics are high, it's all consumption. Whether the retics are low, we are talking about marrow infiltration or aplastic anemia. If there's an elevated LDH disproportionately and macrocytic anemia, we think of B12 folate deficiency. So pancytopenia with lymphadenopathy and organomegaly is not aplastic anemia, and early diagnosis is important, especially when we are dealing with ANC less than 500. So step 1, we look at the count. Is it more than 2 cell lines? All 3 cell lines affected? What is the lab indices? Is it macrocytic or normocytic, normochromic? Step 2, you look at the peripheral smear, see if you can identify blasts. Is there evidence of hemolysis in the form of nucleated red blood cells or spherocytes? And then step 3, we look at the retic count. It's not retic count because it's a marker of marrow function. So before I do a marrow, if they have pancytopenia and the retic count is 7%, I know it's not a marrow pathology. It's peripheral destruction and consumption. So I wouldn't put my money on a marrow in this sort of situation. So bone marrow aspirate will confirm your diagnosis in a child with pancytopenia. We look at the cellularity, architecture, is there granuloma? So this is a normal bone marrow biopsy. You get the cortical bone and all the blue bits are marrow erythropoiesis and the white bits are fat. So normally in children, we should see more than 50% cellularity. That means more than 50% should be all the blue bits. As we age, there's more fatty marrow. This is the hallmark of aplastic anemia. There's hardly any marrow left and there's only fat spaces. So that's how we diagnose. So you need a good biopsy just on aspiration. So pancytopenia, we need a good marrow biopsy. So these are some of the confirmatory tests which I will come to later. So we can come back for each of these diagnoses, how to confirm. So I'll go back and say this is for you to interact with me for all the cases which is going to go on for the next half an hour. So I have 20 cases which we'll discuss and I want to know if you've got messages from these. You're seeing a child with pancytopenia. Do they have liver, spleen? No, they don't have liver, spleen. I'm going to think more in terms of either aplastic anemia or a child with leukemia who's presented early. If they have a small liver, spleen, I think more in terms of infections or leukemia. If they have huge spleen, then I think of hypersplenism and storage. So this is how you would approach clinically. On the lab algorithm, I will look at the blood smear indices and look at the bone marrow aspiration biopsy and then decide whether this is a marrow problem or peripheral consumption and destruction. So this is is it a hypocellular marrow or a hypercellular marrow? So this is what I would do. Then to interpret lab results, just another 2 or 3 tips for you. You have the granulocytic series and the agranulocytic series, which are lymphocytes and monocytes, neutrophils, eosinophils and basophils. Very beautiful cells when you see them under the microscope. Each of them have different lifespan. But you have to know on average, I said for neutrophils and lymphocytes, it's 2 days. and it's different for different age group. So this is also important. So in a newborn baby up to 3 years, they have more lymphocytes compared to neutrophils. After the 3rd birthday, there are more neutrophils compared to lymphocytes. But any absolute lymphocyte count of less than 1500, absolute neutrophil count of less than 1500 is abnormal at any age group. So that needs to be investigated. And so this is ANC, ALC. I've just put an example how you calculate. You look at the total WBC count, what is the percentage of neutrophils, and you calculate. So if it's 43% of 5600, you calculate the ANC. So if you're seeing anything that is low, it's abnormal, and younger children have more lymphocytes. So these are some of the definitions which you can look up. What is eosinopenia, basophilia, monocytosis, monocytopenia. So just look up that it's age dependent. So that's what we need to do in pediatrics. This is for you who are going to interpret lab results. Before, we all had access to peripheral smears. Now we have machine printout. It's beautiful to look at machine printout to get your clues. This is the red cell histogram. The MCV should be 76 to 96, so there is a peak here. This is the platelet histogram. Mean platelet volume is 7 to 9 femtoliter. It's here. So if I have giant platelets, the curve will move to the right. So that means I know it's not a marrow problem. This is the white cell histogram. Very beautiful because lymphocytes are tiny. So this is the lymphocyte population. Neutrophils are big with granules. This is the neutrophil population. So you have two humps, the lymphocyte population, neutrophil population. On a plot, scatter plot, these are lymphocytes, these are neutrophils. So this is just pattern recognition for us to know how to look at the smear. So if without looking at the smear, how to deduce what's going on in the lab. So red cells, beautiful, all have to look similar. 1/3 of the center is pale and they all have to look similar. Platelets are the tiny spots in between the red cells. You can see these are 76 femtoliters, these are 7 femtoliters. So they are so tiny, and both these don't have nuclei. Neutrophils have granulocytic cells, monocytes without the granules, and large lymphocyte and small lymphocyte. Small lymphocyte helps you to tell what is the size of red cell. The nucleus of the small lymphocyte should be the same as that of the red cells. If red cells are smaller, they are microcytic. Red cells are larger, they are macrocytic. Basophils are the only cells that have coffee brown spots even over their nuclei. And eosinophils have the pink granules with a bilobe nucleus. So this is the Coulter machine, just for all of us who never step into the lab. Beautiful principle. Each cell will go through an aperture. As it's squeezing through the aperture, some changes are happening, and that is coming out as a curve. So this is how we get, I told you that this is the WBC curve, lymphocytes, neutrophils. So just based on this, I can say, is the child lymphopenic or neutropenic, because which curve is missing. So these are the differentials, 5 parts. So you can have Maruti car or a BMW. So when you go Maruti, you'll get this. BMW, you can get the 5-part differential. So depends on what you have in your lab. So these are some of the curves that you get when you have more neutrophils, when you have more lymphocytes, when you have monocytes. So just for us to look at a histogram and make a diagnosis. Shall I wait? Yeah, all this is available on the net, you can see. So we said disease groups are infections, drug-induced malignancy, immune deficiency, marrow failure. So we're going to have an interactive 20 minutes, and all of you can raise your hands and tell me the diagnosis. I haven't put any diagnosis in any of the slides. So this is a 2.5-year-old boy who had come with intermittent fever. So that is white cell line. So his story is mainly white cell line. He looks very pale. So that is red cell line. He's got multiple neck, axillary, inguinal nodes, and the spleen is huge, liver is huge. This is how he looks. Anyone wants to raise their hand and think what he has? This is from Tirunelveli. It's not a white person that I've taken out from the net. What am I trying to tell you? Guys, average age here is in the 20s. Come on, you should be like live wires. Come. Chediak Higachi. Okay, so what you're seeing is partial albinism. He's got silvery gray hair, so that's the most salient clinical finding. And what simple bedside tool will you have to say that he's got Chediak Higachi or Griselli? So these are the two syndromes, so you have to look at the hair shaft. So this is a normal hair if you look under the microscope, and here in Chediak Higachi and Griselli, the pigment is not uniform, whereas it goes all clumpy. So it's not uniform pigmentation. So they are prone to HLH. So macrophage go on the rampage. Any infection that comes, so they start eating up all their neighbors, and because of high macrophage activity, there is organomegaly, lymphadenopathy, fever, high ferritin, and they come with pancytopenia. So this is an infiltrative case. So this is a 6-year-old girl from Bangladesh. She's come with progressive abdominal distension, intermittent fever. So there's white cell line, poor appetite, so there's red cell line. Every month she's needing blood transfusion every 2 weeks for the last 3 months. And she's very, very tiny, height and weight for a 6-year-old, only 9.7. So what are you thinking now? Is it marrow problem or peripheral destruction? She's got a huge spleen, so such a big spleen. So hypersplenism. So she's a child with E beta thalassemia. When they are under transfused, the first transfusion they get little bit late at the age of 6 years. Then they develop antibodies against the transfusion. So this is called hyperhemolysis. So such a big spleen, and then they go in for pancytopenia. So her story is not a marrow production problem, but there is peripheral destruction and a huge spleen. So the most striking part in the history is that she's failing to thrive. Although her history is only 3 months duration, for her age, for 6 years, weight of 9.7. So it's something ongoing, but in the last 3 months it's precipitated somehow. Maybe a trivial infection has tipped the balance. So that is the sort of thing that we have to get, that it's not happened overnight. The next child is a 3.5-month-old baby girl who's come to emergency with fever, rapid breathing. Only short history, 1 week. Till then they thought baby was fine. 3rd-degree consanguineous parents. So what do you think she has? She's febrile, she's tachypnic, there's bilateral crepes, V's, big spleen, liver, neck nodes, pancytopenia. Or actually I should say she's got bicytopenia. So what is the most salient feature? What is the most? She's got sunset sign. Did I hear someone say that? Yeah. So there is sunset sign. So you are thinking that there's something that is infiltrating the marrow, and it's happening in the skull bones, and the liver and spleen are huge, and this is a baby who had osteoporosis. So what one test would help you clinch your diagnosis? Anyway, when you see the chest x-ray, you will know that she's got white bones or marble bones. So here they often present with bicytopenia, but the white count will be high. Sometimes when you see a high white count, you have to look at what these cells are. They won't be white blood cells, but they'll be nucleated red blood cell. That's NRBC. Since the NRBCs look exactly like lymphocytes, the machine will count them as lymphocytes. Then it will go back and say, no, these are not lymphocytes, and it will give you a value saying corrected WBC count. So whenever you see corrected WBC count, that means some of the nucleated red cells which are meant to be in the marrow have come out into the peripheral circulation. So something is pushing stuff out of the marrow. So that is abnormal. We should not see NRBC in the peripheral smear apart from newborn baby. So it's physiological in newborn. In all other age groups it's abnormal. So this is the classic X-ray of osteoporosis. All the bones are dense. So the next child, 11-year-old boy who's got fever, pallor, 1 month. So fever and pallor, so 2 cell lines. There's white cell line, pallor, red cell line, bleeds, platelets. So all 3 cell lines are affected. He's got skin, conjunctiva, melena, hematemesis. So there is both skin and mucosal bleeding. He's got generalized lymphadenopathy, pallor, hepatosplenomegaly. Could this be aplastic anemia? No, because there is organomegaly. So this is him with the subconjunctival hemorrhage and a huge bleed here and there is gum hyperplasia. So when there's organ infiltration like this, the most significant clinical feature is that there is organ infiltration. So this is the child who's come with leukemia. So marrow, when it was done, confirmed that this was a child with acute leukemia. So from the history itself, you should be able to say, I'm looking at marrow production problem, marrow infiltration problem, peripheral destruction. So that's what I'm trying to get you to think how to make evaluation, and your tests will only confirm what you already know. So most of what you need to know, 90%, should come from history and clinical findings. So this is a 4-year-old girl with significant cervical lymphadenopathy, splenomegaly, hepatomegaly, intermittent fever. So you got only predominantly white cell symptoms because you've got intermittent fever. So what you're seeing here and what you're seeing here. Some of these are not so common, but I just want you to start thinking, that's all. With cytopenias. So these are cafe au lait spots. So if you see cafe au lait spots in a child who's come with lymphadenopathy, organomegaly, how will you connect cafe au lait spots with organ infiltration? Sorry? Everyone's murmuring. Fanconi anemia. Okay. So I told you that Fanconi, if you have aplastic anemia, everything gets dried up. So you won't have nodes, you won't have liver, you won't have spleen. So this is definitely not Fanconi. Absolutely. There's one thing I'll never say. So she's got big nodes. So I would think in terms of two things which have cafe au lait spots and which are cancer predisposition. One is neurofibromatosis gene. So this is one of the leukemias associated with NF1, which is juvenile myelomonocytic leukemia. So there's some malignancy. So NF1 gene. So just for you to pick up clues that this is the most salient clinical finding. So this is another 8-year-old boy, similar with a 6-month history. So it's not acute. So what is this feature called clinically? What would you call it? A bull neck, correct. So he's so critically placed. Even if he bends his neck, his airway is going to obstruct. So there's pancytopenia with liver, spleen and pallor. So this is the most important clinical feature. What is the imminent danger? From airway obstruction. So this is something that we all need to know, how to perform a basic tracheal deviation. Will you send this child alone to have an X-ray? If you send him, he'll lie down for the X-ray, they'll arrest because the airway is critically placed. So these are things, mediastinal syndrome, they can obstruct their airway. So you have to be very careful dealing. So the clinical features should tell you that this child should not be left alone. They've come in late stage. So this is a child who's presented with Rosai-Dorfman. So he came quite advanced. So with a few days of steroids, everything just melted away. So the next child, 8-year-old girl with intermittent fever, 6 months duration, fatigue, unable to walk. What does that inability to walk say? That there's something infiltrating the bone, bones are painful. So they're not able to walk. So this is a very hallmark thing of marrow infiltration. So there's predominantly white cell and fatigue is red cell. That's the history. What is characteristic on the clinical findings? So there's a malar rash and there is a hepatosplenomegaly. So if she has pancytopenia with malar rash and hepatosplenomegaly, what is your diagnosis? SLE. So it's immune. So the inability to walk is because of joint pain, arthralgia. Okay. So it's not marrow infiltration. Again, these are mimics. SLE is a great mimicker. Every disease it can mimic. So the investigation that would clinch your diagnosis will be dsDNA, which will be positive. A lot of the SLE children can have immune cytopenia. When you do their marrow, it will be cellular. They have immune cytopenia, so they can present with pancytopenia. Some of them initially have presented to us with ITP, then they go to the nephrologist with lupus nephritis, so they move from one department to the other. So SLE is something we always have to bear in mind. 5-year-old boy, acutely unwell fever. So this is a white cell problem. That's how they are presenting, and it's all short history. What you seeing here? Pancytopenia, and this is the mouth. Just 7 days history. What are you thinking of? Great tonsils. What will you think of? Very short history. Nodes. It's not aplastic anemia. So this is hallmark of infectious mononucleosis, EBV. Okay, so how to look at clinical exams? So you know it's not marrow failure because they've got such huge tonsils. Okay, so it's an infective and it's short history, only 7 days. So this is the most salient clinical feature. So the next one is an infant who's come with pallor, painful neck lump, intermittent fever, and otherwise thriving well, has had 2 courses of antibiotics. So already small baby has had 2 courses antibiotics. What does it tell you? They have a problem with their immune system. Babies should not have 2 courses of antibiotics, not in this day and age where most of us can look after a baby in a clean manner. So there's probably something wrong with their immunity. So far already 2 courses of antibiotics given. So there is a neck node, there is BCG adenitis, BCG scar is inflamed, and they have bicytopenia. So what will you think of? What will you think of? Sorry? What will you think of? So BCG site is swollen, there's a BCG adenitis, there's neck node, and there's bicytopenia, anemia, thrombocytopenia. So this is a baby with an immune deficiency. Most likely this could be chronic granulomatous disease. They are having recurrent infections, and it's skin infection with staph plus they can't fight BCG. So it's not pancytopenia, but they present with bicytopenia and nodes. So you confirm your diagnosis by doing an NBT or a DHR test to see if neutrophils can react with the degranulation and oxidative burst or not. So the next child, so it's mainly to listen to the story, that's all. 3-year-old with failure to thrive. So that itself is wrong. So they have failure to thrive, they look pale, they have lymphadenopathy, they have a big liver, spleen. So there's something wrong with this child, and it's a long standing thing, it's not acute. So at this point, will you think of a malignancy? No. The story doesn't tell you of malignancy, something that's ongoing probably from the early infancy period. And this is what I'm looking at. There is the tongue which is filled with thrush and the tonsil adenoid everywhere. So what will you think of with this story and cytopenias? So the previous one was a neutrophil primary immune deficiency. This is more in keeping with a lymphocyte primary immune deficiency. So failure to thrive, pallor, lymphadenopathy, hepatomegaly, I would think of either HIV infection or one of the common variable immune deficiencies where you can get recurrent infections and they can present with oral thrush. So this is a child who was HIV positive. The next child is a 7-year-old boy, failure to thrive. Already there's a history of frequent fevers, malaise, gum bleeding, and clinical examination showing his short stature, hyperpigmented patches, microphthalmia, and pancytopenia. So you look at him. What is the salient feature? Hypoplastic thumb. So here in this child with pancytopenia, and this is a hypopigmented patch. So Fanconi can present with cafe au lait or hypopigmented patch. And what does this show here? This is when you add mitomycin C to the genes, they start breaking. This is normal. Whereas Fanconi, because they can't repair their DNA, they start breaking in a wild manner, and so excess sensitivity to mitomycin C. These are called these Jesus Christ type things, tetraradial, triradial, the Y-shaped ones. So that's all characteristic of Fanconi anemia. So this is the implication for genetic counseling is that it's autosomal recessive. Not only do they have aplastic anemia, but they have a lifelong risk of malignancies. So it's important to cover both. The next child is a 16-year-old boy with mouth ulcer. So this is a white cell history. There was a previous history of jaundice 7 months ago. They had native medicine. Then they've started having blood transfusion in the local hospital. There is pancytopenia, retic count is 0, and they have anti-hepatitis A antibody. So what is your diagnosis? Is it malignancy or aplastic anemia? Retic count 0. What is it likely to be? Aplastic anemia, because they don't have liver, spleen. Hepatitis A induced post-hepatitis A aplastic anemia. It has very good prognosis provided it's treated well. This is one condition. We can give them immunosuppressive therapy, ATG, and they recover well. Okay, so they need to be treated fast. Newborn baby who's presented with a HB of 3 platelets 13,000. What are you seeing here? Huge hemangioma. So this is called Kasabak-Merit syndrome. The hemangioma is gobbling up all the platelets, and as the red cells pass by, they get fragmented. So this is microangiopathic hemolytic anemia. Plasma fibrinogen is also consumed there. So they are in DIC. So this is like a medical emergency. You have to correct the blood product deficiencies, plus you have to act against the hemangioma. Maybe block the feeding vessel, give them beta blockers, give them steroids. So all of this we need to do. The outcome for smaller hemangiomas is good, but this child had the most aggressive DIC and we lost him. Look at this one story, recurrent mouth ulcers and fever. So this is, some of the kids present like this, recurrent fever, mouth ulcers. And I told you that the mouth is a good window to neutrophils. If your neutrophils are healthy, gums are healthy, mouth is healthy. So this, when we check the counts, whenever they have a fever, the neutrophils are low. Whenever they have a fever, the neutrophils are low. So this is a condition that we call cyclical neutropenia. So the clinical clue is the aphthous ulcer. So recurrent mouth ulcers, think of low neutrophil count. So this is one of the things, and that's the clinical clue for cyclical neutropenia. Gingivitis, mouth ulcers, and if the ANC drops less than 1500, that's when they get these ulcers. So this is a child who presented with extensive seborrheic dermatitis and a lump in his head and proptosis. You can see he's not a happy person. So there's intermittent fever and liver, spleen, and pancytopenia. And when we biopsy these lesions, we are seeing something infiltrating. Any part of the body where everything looks similar other than red cells is abnormal. So that's infiltrative. So these are infiltrative lesions of Langerhans cell histiocytosis. So again, these are rare, but something, just the skin can give you a clue. If I said that there were no bony lumps, but the child had quite bad eczema and a low platelet count, I would think more in terms of Wiskott-Ulrich syndrome. So just what is their story? So that's important for us to know. And this child had presented only yesterday to the OP, 13-year-old, and he had pancytopenia for evaluation. At the moment, no splenomegaly, but when he was 7 years of age, he had variceal banding, and these are the huge esophageal varices he had. So here, sometimes what we need to know is they have hypersplenism, pancytopenia, but you can't actually feel clinically a spleen. So chronic liver disease, a liver, healthy cell counts are always a sign that your liver is doing all right. So when the liver patients start dropping their platelet count, things are taking a turn for the worse. So you may not have a palpable spleen, but always pancytopenia, think of liver related disorders, especially hepatitis C. So this could be the first chronic infection, first presentation of a hepatitis C infection. So this is a child who's a 16-year-old male who was very tired. So everyone thought he didn't want to write 10th standard exam. So he came to me and said tired for 1 week and can't walk. Just intercurrent illness, high grade fever, and when we saw there's no lymphadenopathy, hepatosplenomegaly, look quite thin. And the hallmark, what you're seeing here, hyperpigmented knuckles, and this is with pancytopenia. And you could see that by cytopenia mostly, but MCV is so high, 107. This is not a marrow problem because he's got some retic, but the LDH is very high. So this is the hallmark feature of B12 deficiency, because we'll think sometimes it's a malignancy because the LDH is so high, but there's intramedullary death of red blood cells, so release of LDH, so disproportionately high LDH, and because of cell death, uric acid is high, bilirubin is high, B12 is very low. So this is a child who actually had ileocecal tuberculosis, and this was his presentation of, because he couldn't digest the B12, and that's how he had presented. So just to have, you know, quite open eyes to say, always we have to ask the question why. What is the cause of the B12 deficiency? A child who's eating both mixed veg and non-veg diet, if they are Saukarpet ladies who've been on a strict Jain diet, I can understand, but not a 17-year-old boy. So we have to ask the question, what made them B12 deficient? When we see someone with pancytopenia, we always have to think, how are we going to manage them? So for anemia, we give the red blood cells. Neutropenia, if they have fever, cover them with antibiotics. Thrombocytopenia, may need to support them with platelets. We can use tranexamic acid for bleeds. But the treatment is based on what is our definitive diagnosis. So if they have inherited marrow failure syndrome, I would advise early transplantation, hematopoietic stem cell transplantation. If they have leukemias, they will go in for chemotherapy. If they have storage disorders, they'll go for enzyme replacement. Simple megaloblastic anemia, treat with vitamin B12. Always when you start B12 therapy, they can have massive hypokalemia. So we have to watch next 2-3 days because all the cells start building up and the potassium goes down. Immune cytopenias, we have to treat with steroids and immunosuppression. HLH, we have to address what is the cause of the HLH and treat these macrophages with steroids and maybe etoposide. So this is the definitive treatment for a child with pancytopenia. Treat the cause. So first we have to identify the cause rather than just blindly treat. So I'll end with a few key messages. Our clue in a pancytopenia or bicytopenia child is clinical. Do they have organomegaly or not? And your algorithm is based on what organomegaly they have. Lab algorithm is based on whether they are retic response or not. So that is the lab algorithm. And then if you have proper pancytopenia, we definitely need to do a marrow biopsy to find out whether they have aplasia or not. And I want to end by thanking Dr. Srinivasan and all of you for this patient listening. Thanks.